The following podcast is part of a certified educational activity titled Fulfilling a Need in the Management of Patients with Eosinophilic Esophagitis, an Exploration of Novel and Emerging Therapeutic Options. Access the entire activity and complete the post-test at peerview.com/SQH860. Downloadable slides and practice aids are also available.
Good evening, everybody. It's a pleasure to be here and in person and seeing people live for a conference, which is fantastic. Thank you all for coming. The program tonight is called Fulfilling a Need in the Management of Patients with Eosinophilic Esophagitis, an Exploration of Novel and Emerging Therapeutic Options. Tonight I'll introduce my co-panelists, Dr. Amal Assa'ad and Dr. Catherine Peterson. So tonight for the agenda, we have 3 sections for the talks. We'll have the first part, which I'll go through, which is differentiating signs and symptoms of EoE in children and adults, and talk about why early diagnosis matters. And Dr. Assa'ad will go through the second part, talking about examining the limitations of the current standards of care for treatment of EoE. And then Dr. Peterson will talk about the third part, on the horizon, exploring novel and emerging agents for the treatment of EoE. And then, like I said, we're going to go through a case or two after that, hopefully provide some practical tips and do the Q&A. So we'll start with the first part. So we have this consensus definition of eosinophilic esophagitis, kind of the conceptual idea of what the condition is. And EoE is chronic. It's an immune antigen-mediated esophageal disease. And there's 2 key components to it. It's characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. And that's the general framework, and we'll get into the nitty-gritty of how this works. In terms of epidemiology, the prevalence is at least 1 in 2,000 people in Western countries, probably a bit more than that now, and the incidence is about 10 per 100,000. Most of the time, the most common age of diagnosis is less than 50, but really diagnosis can occur over the age span. It's more common in males than in females. We don't fully understand the reasons for that yet, though there's some interesting research on that. And this is something in your practices in GI that you're going to encounter. There have been studies that look, if you're just coming in for an endoscopy, you're going to find EoE in between 2 and 7% of anybody coming into your endoscopy unit. And if someone's coming in with dysphagia, you'll see EoE in 12 to 23% of patients. It's the most common cause of food bolus impaction now. And so if you're doing a middle of the night food bolus impaction, you guys are all eating dinner right now. Hopefully we won't have any impactions during the session. But you'll find EoE quite a lot, and so you should really have the radar up during those cases. Over the years, the prevalence has been increasing, and no matter where we look throughout the world, whether it's in Switzerland or in Ohio or anywhere, in Denmark, it's increasing everywhere. And it's a really interesting thing to discuss, and we can talk about it in the Q&A about why it may be increasing like this. It's a real increase. It's not just increased diagnosis and increased recognition. And when we think about the clinical presentation, the signs and symptoms vary in children and adults. And in children, the symptoms tend to be very nonspecific. So you have things like feeding problems, failure to thrive, abdominal pain, nausea and vomiting. These are in the youngest kids. As they get a little bit older, you may have heartburn, regurgitation, maybe some chest discomfort. And when you do the endoscopy, you tend to have more inflammatory findings. So you see edema and congestion of the esophagus, the white plaques and exudates, and linear furrows. In contrast, in adolescents and adults, it's really dysphagia and food impaction that are the hallmark symptoms. Occasionally, you can see heartburn and chest discomfort. And then when you do the endoscopy, you're seeing more signs of fibrostenosis with rings and strictures and narrowing. And so these are important things to distinguish when you're assessing the different patients of different ages. The important thing to realize is when you're doing the history, it's not just as simple, particularly for the adolescents and adults, as saying, hey, do you have any trouble swallowing? Because most of the time, people will say no. And what you really have to do is delve into the symptoms of subtle behavioral differences with the eating. And this acronym, IMPACT, is a way to think about that. So their I is for imbibe. So you can ask people whether they are drinking a lot of fluids with every bite to get the bites to go down. M is for modify. Are they modifying their foods, cutting them into tiny pieces, pureeing them, chewing really thoroughly, prolonging for P, their meal times? Are they avoiding harder texture foods? Are they chewing excessively? And do they turn away pills and tablets? And when you start delving into this, you could come up with some subtle symptoms, and people may be very symptomatic. But for them, it's just normal. They've had symptoms for many years, and they're not perceiving it as a major problem in terms of symptoms. So it's really important to delve deep into these types of symptoms. In general, the diagnosis can be challenging in certain patients. The symptoms are nonspecific. And when we think about the diagnostic criteria, we'll go through the algorithm in a minute. It's based on symptoms, histology, and excluding other causes of EoE. The presence of the endoscopic findings are supportive, but they're not required in all cases. When you also think about diagnosis right now, we have to do endoscopy. There are no non-invasive ways to diagnose EoE. There's no blood-based biomarkers yet. And the endoscopy is expensive and it's invasive and it's a hurdle. And so particularly in kids, it may be difficult to justify doing an endoscopy. Adults don't necessarily like having them, so that's another barrier. And then the last thing is that when you find eosinophils in the esophagus, it does not mean it's EoE. We'll go through a differential diagnosis of eosinophils and that you have to consider when you're doing this evaluation. On the other hand, early diagnosis is important. We know that if EoE is uncontrolled, it can lead in many cases to esophageal strictures. And I'll show you this data about patients with diagnostic delay. And basically, the longer you have diagnostic delay, the more likely it is to have food impactions and strictures. And feeding dysfunction in children is very difficult. And so many patients with kids who are children have the feeding dysfunction. It's sometimes hard to know the chicken and the egg, which one is the cause and which one is the effect. And many of these children also have failure to thrive, and of course there's a negative impact on quality of life. So these are some data from the Netherlands, where they looked at national data to look at diagnostic delay and the impact on the presentation. So if you look down here on the x-axis here, this is the duration of diagnostic delay from very little to more prolonged. You can look at the prevalence here, and you can see as you have more diagnostic delay, you tend to have less inflammatory predominance and more fibrostenotic predominance. And here now they're looking at strictures and food impaction. So for diagnosis delay of only a year or two, maybe only 20% of people or less have strictures. And if you get up to 20 plus years, at least in these data, this is where this almost 60% of people will now have strictures and food impaction. These data have also been shown in Switzerland, nearly identical, except when they get above 20 years, they're seeing maybe 80% stricture rates. We've seen it in our data at UNC, and there's been data on this from Florida as well. So multiple centers have corroborated this. And this leads to this model of EoE progression that we think happens in many, but not all patients. And so you start, after having a normal endoscopy, normal esophagus, you start EoE with a more inflammatory picture. And as you progress in time with unopposed inflammation, you start getting fibrosis. And then as that time gets longer, the inflammation often persists, but you have additional fibrosis. And so this is why you have this inflammation predominant picture in children, where you get these heartburn, abdominal pain, failure to thrive, feeding difficulty symptoms. And it's not until people either get older or have the disease for a longer duration that you're getting these fibrotic predominant symptoms with the dysphagia and the food impaction. And this also impacts treatment. So if you have only inflammation, you can do anti-inflammatory medical or dietary therapy like we'll hear about. But if there is fibrosis, you have to strongly consider esophageal dilation, because you will not always reverse the fibrosis or get back to a normal caliber esophagus if you don't do that. Now, when we start thinking about into treatments and the diagnostic algorithm, there's been this evolving approach to PPIs. And I think, as many of you know, a PPI trial or non-response to PPI used to be a diagnostic criterion for EoE. But there's been this evolving approach where there's new information coming out that shows that this is not necessarily the right way to go. There are these high response rates to PPI therapy in patients who seem like they have EoE, not who seem like they have GERD. And a number of studies have shown that the clinical, endoscopic, histologic, immunologic, and molecular features at baseline before the PPI trial in these patients doesn't distinguish or predict who will respond to a PPI. There are new non-acid-mediated mechanisms of PPIs to explain their role in EoE, which are really interesting. The PPIs in an acid-independent fashion will suppress this Th2-mediated eotaxin-3 secretion. Eotaxin-3 is the main chemokine that will bring eosinophils into the esophagus. And so the PPIs block that. They also improve barrier function. And in some brand new data just published a few months ago, they've had many effects on the esophageal epithelium, many of which are beneficial. And so based on this data, a few years ago, a large group of people doing EoE research and clinical practice came together to develop new guidelines for diagnosis of EoE without the PPI trial. So PPIs are now considered a therapeutic option. And so this is a little bit how I talked about that. The PPIs were used to diagnose, distinguish EoE from GERD. And then we had this term of the PPI responsive esophageal eosinophilia, where the patients kind of looked like EoE, but they got better with PPI, and we didn't know whether they were GERD or EoE. And so based on this, it now looks like the PPI responsive esophageal eosinophilia term is kind of to the wayside and really shouldn't be used anymore. So these are these updated diagnostic algorithms and the guidelines. So you have a clinical presentation suggestive of EoE like I talked about, the clinical symptoms. It triggers an endoscopy with the biopsy. And a question often comes up is, how many biopsies do we do? And we know from a number of investigators, including Dr. Peterson, that basically the more biopsies you do, the higher your diagnostic yield for EoE is. You need to be doing at least 6 to 8 biopsies from throughout the esophagus, different locations, and you want to target the abnormal findings. If you're taking biopsies from a place that looks normal, the biopsies may also be normal. And so, Kathy did a really clever study, I thought, where you really mapped the esophagus and biopsies from the furrows and areas of intervening that didn't look as abnormal. And it was really those furrow and exudate areas that yielded the highest eosinophil counts. So that's really where you should target the biopsies now when you're doing this. Then, when you find the esophageal eosinophilia, at least 15 eos per high power field is still the threshold, but you can't diagnose EoE yet. You have to evaluate for non-EoE disorders that cause or potentially contribute to esophageal eosinophilia. And once you satisfy yourself that that's not going on, you could diagnose EoE. And we'll go through some practical examples of this in the cases. But this is the differential diagnosis for esophageal eosinophilia. Just like everything in medicine, there's a differential diagnosis. And so you have to think about this. Does someone have diffuse eosinophilia of the GI tract and have a eosinophilic gastritis, enteritis, or a hypereosinophilic syndrome that overlaps? Do they have IBD, a connective tissue disease, some kind of infection or drug hypersensitivity? Now, granted, many of these things can be excluded with a history and physical and a few lab tests, and that's fine, but you have to think about it. I think for all of us where the tricky part comes in is when people do have GERD kind of symptoms, right? Because GERD is common, far more common than EoE. It's something we frequently see. There's clinical overlap, heartburn, chest pain, dysphagia. And there's diagnostic overlap because GERD itself can lead to eosinophils in the esophagus. So sometimes this can be tricky to distinguish. And then here, we're not using the term the PPI responsive esophageal eosinophilia anymore. Okay, so then when we're thinking about the diagnosis, you should recognize the endoscopic findings of EoE, and these are some illustrative examples. This is a picture of really the inflammatory findings. So you have exudates, these are the white plaques. This is not Candida. These are thought to be eosinophil microabscesses here. You have the linear furrows that train track up and down the esophagus, and a more subtle finding is edema, okay? We don't have a picture of a normal esophagus, but as for those of you who do endoscopy, you can see a fine lattice work here of blood vessels in the esophagus. That's totally gone here. The esophagus is congested and edematous. This is a picture of a patient with mild esophageal rings. There's also edema here and maybe a little bit of exudates, a subtle furrow. And then, of course, this is a fairly severe stricture here in the proximal part of the esophagus. And then, again, the findings overlap, right? So you can see rings, you can see furrows, you can see exudates, and it's very edematous. Now, when you're doing this clinically, I strongly recommend you use the EoE endoscopic reference score to grade the endoscopic severity of the esophagus. This was developed by Iko Hirano and colleagues out of Northwestern, and the acronym not only stands for EoE endoscopic reference score, but they're very clever with their acronyms. It also stands for the 5 findings that you should look at, which is edema, rings, exudates, furrow, and strictures. The only confusing part is when I do this clinically, I add an X here, so there's not 2 E's that can get you confused. But you have grades. These are all normal, and then edema can be mild or decreased or absent vascularity. Rings are subtle, like little speed bumps. moderate, distinct, but the scope goes through, and severe, where the scope does not pass. Exudates can be mild, where it's less than 10% of the esophageal mucosa, or severe, where it's more than 10%. You can have furrows, which are very mild and subtle, or severe with visible depth to them. And then the strictures are just absent versus present, but you should try to estimate the size of the stricture. And this is really useful because, one, it's a common language. So if you guys do a procedure and you do EREFs, and then I see the patient, I can understand what you're talking about for endoscopic severity as opposed to a general description. It's also incredibly helpful for tracking patients over time. If you look at someone and say, okay, they have exudates, edema, rings, and furrows at baseline, and then you treat them, well, and they still have exudates and furrows and rings, have they improved? Have they gone from severe to mild, or have they resolved? So I think those are very important to do. So in summary, EoE is a clinical pathologic disease that continues to increase in worldwide incidence and prevalence. The EoE diagnostic criteria have been updated. And so remember, it is clinical pathologic. So you need the symptoms and you need the histology. The PPI trial is no longer needed for diagnosis. The PPIs are now considered to be EoE treatments. Diagnosis is made with the symptoms and 15 EOs. It does not have another contributing cause. When you talk about the symptoms, think about eating behaviors and that IMPACT acronym. And in many patients, not everybody, but in many, EoE is progressive from inflammation to fibrosis. And early diagnosis likely will reduce complications if you can treat people successfully. So I think those are the main points to talk about. One other thing that I'll just mention about the PPI trial is you do have to give this some thought when you're doing your diagnostic evaluation, because if someone comes to an endoscopy on a PPI and it looks normal, you don't know whether they had EoE or not. It may be that the PPI is treating them, right? And so if someone has dysphagia in my practice now, I'd go directly to an endoscopy. There's not really an indication to treat a patient with dysphagia alone with a PPI. If someone has heartburn and dysphagia and they come to the endoscopy on the PPI and it's normal, at some point you may have to consider pulling the PPI off and seeing what the underlying condition is if you have some suspicion for EoE. So that's a point related to the PPI that you have to consider clinically. Okay, terrific. So we're going to move on, and I've already introduced Dr. Assa'ad, and so she's going to talk now about examining the limitations of the current standard of care for EoE. Thank you, guys.
Thank you very much, Dylan. I'd like to thank the organizers for inviting me, and I'd like to thank you all, my fellow gastroenterologists, for having analogists in the middle of you. So I have worked with EoE since possibly its inception back in the 1990s. I know I look really young, but yes, it's been a while. The other thing I have to say that I work with pediatric EoE, mostly than adults, but have come to the realization that EoE goes from really the babies all the way to adult life. So it's a continuum, and one has to be aware of that. So the goals of this talk is to go over EoE management. And as you can see, we use the word management and not treatment or cure, because we just manage the disorder. And the treatment or the management has to start with the goals. What is the goal of doing this management? Is it to control symptoms or control inflammation, or both? And also we have to realize that it's not enough to just look for histologic improvements, but because you can have histologic improvement, but you still have symptoms. Or the most common actually is that the symptoms improve, but the histologic picture does not. So we have to target both aspects of the disorder. And then the thing that I have worked on the most is looking at the natural history of EoE. And it is a chronic condition, it's relapsing, it comes and goes, and so long-term management is very important. So what are the suggested approaches to managing EoE? And obviously there's two places where you can start. And the one is medical therapy, which is, as Dr. Dillon mentioned, PPIs or topical corticosteroids, and we're going to talk about this in a minute. Or you can start with diet therapy, which could be empiric treatment or skin test and blood test directed therapy. Now, if one fails, you can go to the other. If one fails, you can go to the other. So it's almost like a trial and error here. Now, if you have a response, remember we said it is a chronic disorder, so if you have a response, you have to move on to maintenance therapy and follow up. If you don't have a response, you end up with strictures, and if you end up with strictures, you'll have to get to dilations, which is not a very pleasant thing to get to. So we try to treat symptoms, mostly symptoms of dysphagia, without the need to avoid food based on textures. And this is written this way because you may have to avoid foods based on them being highly allergenic foods, or these are the part of the dietary management that has been shown to be beneficial in management of EoE. Now, in histopathology, the target usually for clinical purpose as well as for a lot of research is to resolve the eosinophilic inflammation in the esophagus, which is in general less than 5 to 15 eosinophils per high power field. And that's usually counted in the most dense area of eosinophils in the esophagus. And then also looking at endoscopy, the aim is to treat to improvement inflammatory features that, again, Dr. Evan has talked about, and targeting a diameter of more than 15 millimeters, so there is no strictures. So these are the two approaches. One is non-pharmacologic and one is pharmacologic. And as you may all know, there is not an FDA-approved medication for EoE yet, even that we've been looking at this disorder for now over, I would say, 25 years. So the non-pharmacologic treatments are dietary elimination, which could be elemental formula, empiric elimination, and targeted elimination, and esophageal dilation. And we'll talk about the formulas in a minute, or the dietary treatment in a minute. The pharmacologics are the proton pump inhibitors that you heard now are not just a prelude to have to be used before you diagnose EoE, but they are considered a treatment of EoE. And then the corticosteroids, which could be systemic, which of course in pediatric age we try to avoid them like the plague. We do not want to give a child steroids systemically, but you can use the swallowed topical steroids, which some are the standard and some are novel formulation we'll talk about. The other treatments, the leukotriene antagonists, the mast cell stabilizers, have not really been shown to be that effective, so we hardly use those. There are some biologics and other small molecules that I think Kathleen will talk about. So what are the dietary recommendations? There is approaches that have been used in infants and adults. And the first one is totally elemental diet, which is amino acid-based formula. And in fact, the first possibly report of response to this treatment was a report from Dr. Sampson, Hugh Sampson, the allergist in Mount Sinai, who was reporting that these kids who had just terrible problem taking regular formula, when they were put on an amino acid-based formula, and this was the start of amino acid-based formulas, they did so much better. And incidentally, they had looked at the esophagus and had found that they used to have eosinophils, and after they were put on the amino acid formula, they didn't have eosinophils anymore. But they had not at that time coined the term eosinophilic esophagitis. So that's where that came from. And then there was a lot of work from different institutions, and where it showed that when you put those infants on amino acid-based formula, they do much better. And as Dr. Evan mentioned, the symptoms in the infants was very nonspecific. So it's this baby that cries a lot, that is just difficult to console, is up all night, and then in the like the toddler age, it's those infants or the kids who just throw up, like every now and then they just show up, and quite often they show up, and then they go about doing whatever they're doing, and then they show up again. The other treatment is empiric elimination diets, which is removal of common food triggers without testing, and we'll go over that in a minute. The targeted dietary allergens is where we had started. So way back, we started by skin testing everyone to all and every food that can be imagined, and then removing from the diet the things that were positive by skin tests. And then eventually, the group from Chicago found or thought, and they're gastroenterologists, not allergists, they thought, well, if common things are common, so instead of testing, let's just go ahead and remove the common food allergens. And this what became the 6 food elimination diet, or SOFID. And then the guidelines actually recommended diet over no treatment. So if you do diagnose eosinophilic esophagitis, you want to do something about it. And based on the evidence, doing a diet is better than not treating. So considered first-line treatments, you have to address the underlying allergic mechanism. The benefits is, of course, you have non-pharmacologic approaches, low-cost safety profile. The disadvantages is like, who wants to be on an elemental diet or remove milk, eggs, peanuts, tree nuts, shellfish, and fish and wheat from the diet? It's very difficult to do that. And then these approaches have been used with repeated endoscopies, so that you know, when you remove the foods, you try to see has the esophagus improved, and then when you introduce some of these foods again, you again want to look and see, did the disease come back? So there was a lot of, it requires a lot of endoscopies. And of course, when you remove a lot of foods from the diet, there's the risks of nutritional deficiencies with these eliminations. So the guidelines looked at the diet, elemental diet, over no treatment, the difference between that and no treatment. And they made a conditional recommendation that you want to use elemental diet over no treatment. And you can see the forest plot here for not achieving histologic remission. Again, it's a conditional recommendation, and because the quality evidence is not that high. And we just talked about the limitations of doing these elemental diets, but again, they are better than no treatment. How about the allergy testing directed diets? Again, the American Gastroenterology Association Joint Task Force suggested that allergy testing based elimination diet over no treatment is better. And again, it's a conditional recommendation, and despite the fact that there's so many studies, the quality of the evidence is low. Because these are things that are so difficult to run a study. You know, you have to make sure that the patients are compliant with these kinds of diets. You have to plan it correctly. You can't really hide food from adults who are eating a diet, you know, give them placebos and things like that. So you can imagine that these are hard studies to do, and that's why you have low evidence, despite the fact that there are many studies. Okay, so it boiled down now to these 4 approaches. Like I said previously, we started with a lot of the dietary elimination, and then the 6 food elimination diet came about, and then there was the 4 food elimination diet, and then now it's been really most recommended that you would try the cow milk and wheat elimination diet, and then possibly also just cow milk alone. But what happens with the elimination diet? Remember, we said that eosinophilic esophagitis is a chronic disorder, and the treatment is sort of long and prolonged. So you want to set up the elimination diet. Try 2 foods first. If it doesn't work, you have to do an endoscopy, of course. You do the 2 foods and then give it time. If it doesn't work, then you might go to the 4 food elimination diet. Once more, you know, try it. If it doesn't work, you might have to go to the 6 food elimination diet. But once you got to a place where you're happy with and the patient, of course, is happy, that's important, with the outcome, then you try to step down again. You know, you add some of the foods that have been eliminated, And you can assess that by either endoscopies or by sometimes patient symptoms if you feel that you're going to end up with so many endoscopies. So in general, the recommendation is to do food introduced every 2 to 4 weeks and then followed by an endoscopy. So at least there'll be 6 endoscopies here. Okay, so another recommendation is in patients with symptomatic eosinophilic esophagitis, the AGA, GHF suggests using PPI over no treatment, and this is what Dr. Evans talked about. Again, it's conditional recommendation because very low quality evidence, despite a lot of studies, but you can see the forest plot, it's almost like equal on both sides. So how about the treatment that seems to work the most, the swallowed topical steroids? The concept is pretty much like you treat asthma with inhaled steroids. You could treat eosinophilic esophagitis with steroids that are puffed and swallowed so that they deposit in the esophagus and do the anti-inflammatory effect. There has been multiple randomized controlled trials that demonstrate the benefits of the topical steroids in children and in adults. And these have mostly used budesonide or fluticasone. You have to know, the proper use and teach the patients how to use these inhalers or how to do the topical budesonide that we call viscous budesonide. Now, of course, all of these have a risk of oral candidiasis. However, in our practice, we hardly see that, and sometimes we think it's because the patients are not using them, or it's just, although we talk a lot about it, it's not a common finding that we see. So this is really the only strong recommendation in the guidelines to support the topical corticosteroids over no treatment. And then the issue is, remember we talked about being long-term. So sometimes the symptoms occur after discontinuation. So you have to assess the efficacy with follow-up endoscopy after 6 to 12 weeks of therapy. So the two steroids we talked about is the fluticasone propionate, which is used from a multi-dose inhaler, puffed directly in the mouth and swallowed. There are quite a bit of recommendations of how to use that, like how you space it away from meals so that it does go to the esophagus and doesn't get washed away with the meal. The recommended dose after many studies has been a bit higher than you would expect you would want to use, but it's a 440 to 880 micrograms twice daily for 8 weeks in adults. And we actually use that in children as well, even though, again, that looks like a large dose for a child. And there is really need to strict adherence. The viscous budesonide is where the liquid budesonide is added to a sugary base that makes it viscous. So the idea is it doesn't just go through the esophagus immediately, but it rolls down slowly and again coats the esophagus. And this has been sort of a very good lifesaver for the little children who it's hard to do a puffed steroid for them. And there is quite an evidence that there is complete histologic emission with that, even better than the nebulized treatment. So this is, like I said, is one of the strongest recommendations with still moderate quality evidence, but you can see that in the forest plot that everything is on this side based on the multiple studies here. So what's the maintenance therapy? So when treatment is stopped, the disease activity occurs, and typically rapidly. But in one study I've done quite a few years ago, it was the more you follow up, the more it comes back. So the longer the period of follow-up, the more you see return of the disease. So these are the disorders that I call, they make the patient your friend and your lifetime friend because they'll always come back to you. So ongoing maintenance therapy should be considered in all patients. It's indicated when there is evidence of chronic remodeling, in particular, recurrent food impactions, severe symptoms, or rapid return of symptoms when off therapy. And we need really more data on that. So that recommendation about topical steroids is very interesting because in guidelines that are evidence-based, they always not just weigh whether you get relief of the disorder, but they also weigh what's valuable for the patient. So what is of higher value? So if a patient places high value on not wanting to take steroids, then you're going to use the dietary management. If a patient places a high value on not limiting their diet, then you want to use the steroids. The esophageal dilation is what we would like to avoid, but sometimes, and we sometimes see that even in adolescents and young adults who commonly present with the impaction rather than the vague symptoms in the younger infants. So it provides immediate and long-lasting relief of dysphagia, and it's a reasonable initial treatment for patients who already have strictures. You might have to start with that. Of course, it has all the disadvantages of dilation that you all know about more than I can tell you. There's other methods to monitor the disease that there are methods that are invasive and some non-invasive measures. The non-invasive measures are still sort in the research stage and not really available for clinical use, but things like checking for the Th2 cytokines, which are the allergic inflammatory cytokines in the saliva, exhaled nitric oxide, which is pretty much like you can use that for asthmatics, how much nitric oxide is in the breath. And also there is a urine test, the 3BT. Otherwise, the method to monitor the disease is commonly the endoscopies, although there's other forms of looking inside the esophagus, which could be like the string test that's here, or other doing like a ultrasound of the esophagus, and endoscopic ultrasounds. So as Dr. Evans mentioned as well, there is a long list of diagnoses, differential diagnoses you want to look at, but then again, the current treatments are this, as I mentioned earlier, you go medical therapy or diet therapy, and you go back and forth to achieve the most improvement. And then if you do improve, then you want to really consider strongly the maintenance therapy. If you do not have improvement and you end up with the strictures, you end up doing the dilations. So in summary, and we've said this many times, no FDA-approved treatment yet for EoE, but the current treatment includes these 3 Ds, the diet, the drugs, and dilation. Obviously, EoE likes a lot of mnemonics here. So it's a chronic disease. Maintenance therapy is required, and treatment, if stopped, the disease recurs, and sometimes quite rapidly. And I think I'm done, and I'll pass it on to Dr. Catherine Peterson.
Thank you. Thanks for staying for the last part of the talk. I appreciate it, and thank you for inviting me from the organizers. I appreciate that too. I get to do the really fun part, which is we talked about that there's no FDA-approved therapies, but I get to talk about the potential future and the what ifs. So I get the part that's the best part, I think, to end on. I'm gonna start with EoE pathophysiology, because this is kind of what we're thinking about in treating these patients. So we talked about that we have some off-label use right now, and there's some drugs under study, but really what we need to know when we're trying to treat our patients is what's going on. And the thought is that this is a Th2-mediated disease. It's an allergic disease, or what we refer to as kind of an allergy-based disease, and that results in eosinophils infiltrating into the esophagus. And that's why we call it eosinophilic esophagitis, because we can see those eosinophils so well on the biopsies. But what we have to realize is underlying the underpinnings of all of this is the antigen that then triggers these responses in the esophagus, and these immune responses that then result in the eosinophils coming in. And the eosinophils are part of a very large process that goes on. And when they do come in, and this immune process happens, as Evan so nicely demonstrated, it results in this esophageal dysfunction, in fibrosis, and these are these patients that we see, and sometimes we were just talking before the presentation today, sometimes we see them and we're like, oh my gosh, I don't even know if I can get a scope down that. So we're trying to avoid that from happening. And so there's a lot of therapy out there that's being studied to try to help these patients so that we're not dealing with sequential dilations because they're so fibrostenotic by the time they come in. One thing that we need to know is like the way that the eosinophils are getting recruited and the immune response is happening as we get this antigenic stimulation, food, maybe microbes are finding some new microbial changes in the esophagus, maybe pollutants, maybe aeroallergens are coming in and triggering an immune response. And that immune response is being triggered in part by what's called alarmins that then trigger in Th2 cells and T cells that we think is kind of the mainstay of the disease that then secrete these cytokines. And so the thought is like, let's go after the cytokines. What are these things that we can treat? Well, we can treat IL-4 and IL-13, and I'll go into a little bit of data on drugs that are actually targeting these mechanisms. We can go after IL-5, which recruits in the eosinophils themselves. And then also we could go after eosinophils or mast cells as part of the disease. But it's a whole big process that results in remodeling, in fibrosis, in actually what we're seeing now is like the epithelium, and I'm sure you see that too when you do the endoscopy, the epithelium being disrupted and abnormal. So there's a lot that goes on in the esophagus more than just an eosinophil coming in. What we do know, and what Evan actually looked at, and then Dr. Assa'ad in this study here, is that atopy is common in these patients. So often they'll present and they actually have allergic disease. And what is fascinating is if you look at this table here, that asthma occurs 4 to 5 times more than you see in the normal population. But you also see allergic rhinitis, you see dermatitis, you see food allergy and anaphylaxis at higher rates than you would see in the normal population. And what we've looked at a little bit is familial inheritance, and we've been able to track asthma out in families really, really far out into first, second, third, and fourth degree family members in families with eosinophilic patients. So why do we want to think about biologics for EoE? It's just a disease that hits the esophagus. What do we need to think about when we're trying to look at therapies for EoE? We've talked about some of the stuff we can do on the side. Well, we can do diet, we can do PPIs, we can do these non-FDA approved therapies, but sometimes they don't respond. Sometimes you get corticosteroid refractory or intolerant patients. They can't handle the drugs that they're taking. Also, we have these patients that we just talked about that come in and have unbelievable asthma or unbelievable atopic dermatitis, that maybe there's a drug, one shoe fits all kind of issue that we could deal with our patients. And so that's one way that we could try to approach our patients is kind of more of on a personalized approach and personalized medicine. We think the biologics have benefits in the remodeling and the fibrosis for these patients. And then, knowing that we're dealing with young patients, and I have a family member with EoE, and I can tell you right now that they are not compliant with, multiple daily therapies. So maybe something that we could give them once a week, once every few weeks would be something that would result in better compliance in our patients. What we do know so far is everything is in research. So even the American Gastroenterology Association and the Joint Task Force guidelines basically said Xolair is probably not going to be helpful. So we're not going to worry about these anti-IgE therapies, even though a lot of these patients actually have IgE-mediated food allergies. But these other biologic therapies, like we talked about IL-5, that is involved in eosinophil recruitment, that we know that IL-13 and IL-4 that are 2 major cytokines with allergic responses, maybe there's a place for them, but not now. Right now, the place would be maybe in research trials. But it's something to think about, and it's something to keep in the back of our mind. So a lot of the IL-4, IL-13 mechanisms, a lot of these receptors that are involved in the epithelial cells, the immune cells, IL-4 can work through, and IL-13 can work through these different receptors. IL-4 alpha subunit is on one of the receptors, then they compare with what's called a gamma subunit, or you can have IL-13 alpha 1 or alpha 2. What's interesting is there actually is a biologic out there that is FDA approved for moderate to severe atopic dermatitis, moderate to severe asthma, or chronic rhinosinusitis with polyps, dupilumab. And this works by actually blocking that IL-4 receptor alpha subunit, which then actually works by more than just blocking IL-4. It blocks the mechanism of IL-13 on this type 2 receptor. So it actually has a dual mechanism of action in allergic disease. There has already been a phase 2 study, and Dr. Dillon has been part of this, where we actually looked at dupilumab and randomized controlled trial 1-to-1 for about 12 weeks in patients that were older, 18 to 65 years of age, and they randomized either to placebo or dupilumab, where they had a loading dose and then weekly injections. They did this for about 12 weeks, and then they had a follow-up afterwards. And what this study showed, if you look at the far left graph, is that symptoms were dramatically reduced, and we expect a placebo response. We do. Most trials do show a placebo response when we do that. But we see dramatic difference in the decrease in symptoms. We see actually a dramatic decrease in histopathology with eosinophil infiltration and an improvement in that endoscopic reference score. So we see on multiple different levels the symptoms that we talk about in the 3 domains, the actual histopathology, and the endoscopic scores that we got improvement in a lot of these patients. We are now finishing up, and actually I think Dr. Dillon's going to talk about this during ACG, the Part A, that has been finished. They completed the phase 3 trial with 81 patients that were then randomized, again, to dupilumab or placebo over 24 weeks, so a 6-month randomization. And it actually, in that randomized trial, I'm going to move on to the next slide, it actually, dupilumab met all of its endpoints. So it actually improved, if you look at the top line, it improved eosinophil counts. So in 59.5% of the patients that were in the dupilumab arm, they improved their eosinophil counts to less than 6 per high power field. And that is the FDA cutoff for the pharmaceutical industry, as compared to 5% of the placebo arm. It actually improved the dysphagia score, and then even below in secondary endpoints where they're looking at other changes in the esophagus on the biopsies, demonstrating potential remodeling, shows a huge difference between the dupilumab arm and the placebo arm. In addition, the endoscopic score improved, and the peak eosinophil count, even if you expanded it to less than 15, it was superior in the dupilumab arm. Well, we can just target IL-13. There is a monoclonal antibody out targeting IL-13 and inhibiting IL-13's mechanism in allergy. And it actually inhibits this binding onto both IL-13 receptors, and it's in a weekly injection as well. There was a prior trial that looked at this in 16 weeks in a randomized controlled trial, and it's a subcutaneous therapy. And the primary endpoint was actually the mean change, the change in the mean eosinophil count. And if you look over here, that is that far left graph. And in that far left graph, what you can see in the orange is that's placebo, pre and the baseline, and then week 16. But look at both in the low and the higher doses of this monoclonal antibody against IL-13, you can see there's a dramatic reduction in eosinophil counts. In addition, the endoscopic scores improved dramatically as well, both in the lower and the higher doses of this monoclonal antibody. What's really interesting is if you look at the population, that higher dose resulted in a trend towards really improved dysphagia scores. And it really stands out if you look at the right-sided graph here, where you show a dramatic decrease in the dysphagia scores in the higher dose of the IL-13 antibody. So even though it looks like the changes were fairly similar between the low and the high dose, the dysphagia scores improved dramatically in the higher dose of therapy. Again, they took these patients and they put them in an open label extension, because you want to know if you can treat a patient for 4 months that you can maintain therapy and they maintain remission. And what they found is they actually kept them in an open label extension trial for 52 weeks. And at the end of that 52 weeks, what they found is that the eosinophil counts remained about the same as when they first finished that randomized controlled trial. So staying on the medication or initiating into the medication, the eosinophil counts would reduce and then actually maintained throughout that whole time. So it looks like it actually can be maintained for 52 weeks with maintaining its response in the patients. There's another biologic that's out there that is not right now, doesn't have data in EoE, but is being currently studied in EoE. But it has data in eosinophilic gastritis and or duodenitis, so eosinophilia in the first part of the small bowel. And actually, Dr. Dillon published this last year as the results of a randomized controlled trial looking at eosinophilic gastritis and or duodenitis with what's called lirentelimab. And what lirentelimab does is lirentelimab is an antibody that actually hits something called Siglec-8. And when it actually will join Siglec-8, it causes the eosinophils, it causes basically apoptosis of the eosinophils, antibody-dependent cellular cytotoxicity. So they go away. So in this trial that these patients were randomized, they had gastritis and enteritis, and we're going to have to change all the duodenitis, all the small bowel involvement. They actually show over time, over about a 3-month period, they could dramatically reduce their symptoms. So these symptoms of even some of these patients with gastritis and duodenitis are actually improving by just depleting the eosinophils. Again, we don't know the data yet in eosinophilic esophagitis, but that is something that is ongoing right now. So let's move a little bit away from the biologics and just talk a little bit more about topical steroids, because right now we're kind of dealing with the fact that nothing is FDA approved, but there are studies out there looking at different formulations of topical steroids. So budesonide oral suspension has already finished a phase 3 trial where they actually looked at adolescents to adulthood, 55, which to me is still young, just so you know. And so I kind of feel like it's the younger population. But they looked at this and they actually showed when they did a 3-month trial in these patients that they got improvement both in histopathology and eosinophilic scores compared to placebo when they did it twice daily. And they also got improvement in the symptom score. So they got a symptom response as well. But what's interesting is they had a very large placebo symptom response in the trial, even though they tried very hard to control for that. So it's an interesting finding that they found from this, but they did show that on a histopathologic level, things improved by doing budesonide oral suspension. There's a different formulation of this, or a different formulation of budesonide, which is called an oral dispersible tablet that's actually out in Europe that has been through trials. And this was, again, a phase 3 randomized controlled trial where they looked at the efficacy of 3 months of the oral dispersible tablet, which is going to be probably pretty easy for our patients to take. And they showed that in about 50, almost 60% of patients, they had both clinical improvement and a pretty stringent criteria for this and histologic improvement. And about 90% of them had histologic remission. So not everybody had clinical improvement when they got histologic improvement, but they had a pretty good result for both with pretty stringent criteria. They showed that they had what's called an ESI score that had improved, which is like the 7-day recall of how bad their dysphagia is. And they also found that they got endoscopic improvement. So this oral dispersible tablet actually has potential, but right now it's not in trials that I know of, and we'll have to ask Evan that. In the United States, it's just being studied in Europe. Well, there's more. So I know I've probably already talked your ear off with what is out there, but it's kind of an exciting field because as you can see from what I've told you already, nothing is 100%. So we're not getting 100% on anything right now. So it's going to be a very similar form of inflammatory kind of disease where there's going to be different phenotypes and people are going to respond differently to these therapies. So other drugs that are under study currently are fluticasone, ODT, which has some data behind it. It's in a phase 3. I think they're finishing up their phase 3, or about to, yeah. And then also etrasimod. So we're familiar in GI with ozanimod, which is a sphingosine 1-phosphate receptor modulator, which I think is FDA approved now for ulcerative colitis. And etrasimod is its kind of cousin, targeting 2 of those receptors, with the thought that if you can inhibit that lymphocyte, that T cell trafficking into tissues, you can inhibit that signaling that's occurring and maybe result in improved EoE. There's a phase 2 trial in mepolizumab, which targets IL-5 right now. And so the idea is to use mepolizumab, and it's already FDA approved for asthma. And then another one undergoing right now called benralizumab, which targets the IL-5 receptor on eosinophils. Both mepolizumab and benralizumab are already approved for asthma or eosinophilic asthma. So they're out there and they have data behind them in asthma. So in summary, I probably filled you full of all sorts of stuff, and it's kind of a fun time because it is a little confusing to figure out how to manage all of this, but I think the goal of the conversation is just to say there's all these potential therapies for these patients that are so difficult sometimes to manage. And there's so many new treatment options out there, although all of them right now especially are in exploratory phase, nothing is FDA approved. But I think the interesting thing that we need to think about is as we're dealing with our eosinophilic patients is to really realize that they have these elevated risks for atopic and other immune-mediated diseases. And this is that kind of nice time for us to sit down with our patients and realize we can start to deliver more of a personalized approach to our patients. and start thinking about what other comorbid conditions they have and how that can fit into a treatment algorithm to treat them, to give them a better quality of life. All right, so I'm going to move it on because I actually think one of the best things that we can do is just talk about cases and talk about how we would approach cases or how other people might want to approach cases, because I think we all have those cases that can be potentially difficult and give us learning tips. So I think I will hand it over to Dr. Assa'ad for her first case.
All right, thanks, Catherine, and thanks, Dylan. I've learned a lot from both of you. So this is a case that I'm presenting almost in flashback. So here's a child who today is 9 years old. He's a white male who's been diagnosed with EoE. And when I looked back in his chart after the diagnosis, I found that 3 years ago, prior to the diagnosis, he had presented with abdominal pain. He even said, for a 6-year-old, he was 6-year-old at the time, he said, well, he gets pain in his back while he's eating. And he also had lots of canker sores. He had been diagnosed with reflux esophagitis after an upper GI, and he was treated with ranitidine daily for 3 months and gradually weaned off when asymptomatic for 4 weeks. But then once they weaned him off, his symptoms had occurred after several cycles of treatment. And when I went, 1 month back, he had this endoscopy and biopsy which showed basal layer hyperplasia, transepithelial eosinophils, and papillomatosis. And his pathology diagnosis at the time was reflux esophagitis. And then in the addendum, they said, well, there is 5 to 25 eosinophils per high power field with marked degranulation. So this is the picture of a normal esophagus where you can see up here there's no inflammatory infiltrates. The papillae are 50% here, and the basal cell layer is nicely arranged and not hypertrophied. However, in his pathology, it would look like this. He has a lot of eosinophil infiltration here. This is what on endoscopy you see as like white exudate or what's sometimes called eosinophilic abscesses. And then the papillae are way up there. They're not just 50%. And the basal layer is heaped up 5 or 6 layers here. So when I looked back, when he first presented at 1 year of age, this child had cow milk allergy. He was diagnosed with cow milk allergy. And his symptom was vomiting of cow milk formula at birth. And then he was changed to soy. At 9 months of age, he had skin tests to the milk, which were positive. He had the peanut sensitization when he had not even had any peanuts yet. His IgE to peanuts was more than 100, which is basically the top range of the assay. He was sensitized to eggs, and he's, again, 5 kilounits per liter with his egg IgE. And he had, though, after that, we did a food challenge at 20 months, which was negative to eggs, which is not uncommon, that younger children would be sensitized to eggs, and then within a year or so, they're not anymore. So now we're back to today. So at this point, he avoids peanuts and a few tree nuts because remember, he was positive to peanuts when he was younger. If he takes a lot of soy, it causes skin itching because he has eczema. He now takes cow milk products and eggs because we did the challenge there, and he outgrew his milk allergy, symptomatic milk allergy. His skin prick tests to a large panel of food allergens showed positive to soy, tree nuts, beans, and peas, which are legumes, which when we used to do a lot of skin tests in those patients with EoE, having positive legumes was very common. So not just the peanuts, but the beans and peas, especially in someone who had peanut allergy. And as you can see here, some of his skin tests and some of his IgE levels. So he also has intermittent asthma. His eczema, which used to be more severe, is now mild with occasional flare-ups. And then he has allergic rhinitis symptoms, which we know that kids who start with eczema, then they develop allergic rhinitis at the age of, then they develop asthma at around 5 years of age, and then when they get a bit older, they develop the allergic rhinitis. and his skin tests are positive to moles, grasses, trees, and cats. So what I wanted to discuss here is this relationship to atopy, and also the long time until those patients are diagnosed. And when I looked at this chart, I thought, well, this child must have had EoE since he was a year old, or maybe even when he was 6 years old, and when he complained of the gastrointestinal symptoms. But we know there is a time lag in the diagnosis of EoE, and I think it persists now even in adults, even with the general knowledge about this diagnosis. What do you all think?
Yeah, no, I think that's, very interesting. And you're talking about this kind of march of allergic conditions, or the atopic march. And I think one question that comes up clinically all the time is, and you're even saying it with this, kids will grow out of eczema, they'll grow out of food allergies. What's your answer when someone asks you, will my child grow out of EoE?
Well, I would say they probably will not. We can control the disease, but they may not go out of it, unless we have sort of a much better treatment.
My question for you is, how did you approach that? Did you do diet and get a dietitian involved, or?
Well, in this particular child, we started with the steroids, the topical steroids, which would be the Flovent puffed and swallowed, because he also had asthma. So we started with that. And when that worked very well, but then the parents, as we expected, didn't want the child to be on a lot of steroids. So we went back to the dietary management, which would be, in this case, removing milk from his diet.
Is that usually a lot of times first line in children is to remove dairy proteins, to try not to take too many of them out?
That's correct, right? He was at an older age, like he's 10 now, so he doesn't need formula, and so we wouldn't go to just a total elemental diet. We just remove the few foods, like we said, either do the 4 food elimination or the 2 food or 1 food. In this particular case, he wasn't eating peanuts anyway. Removing wheat is very difficult in children's diet, but removing milk is a bit more easy, and so we did that.
So I think one thing that I'd like to, or at least point out, we have a multidisciplinary panel up here, and you're hearing, I think, sort of the allergic nature of EoE, both in the presentation and in the way that we're targeting some new medications for EoE. And I think it'd be interesting to hear perspectives on how you work with gastroenterologists and how you feel like the collaboration is from the allergy perspective, and maybe Kathy, how you work with the allergists more from the GI perspective.
Yeah, so it's a two-way street, because who is the person who's going to diagnose the EoE? It could be the allergist, and it could be the gastroenterologist. And if it's the gastroenterologist, then they quickly see that those patients have allergic disorders, so they do send them to the allergist for diagnosis and management of the other allergic disorders and assisting in the management of EoE. Of course, if it's the allergist, then we have to send them to the gastroenterologist to do the endoscopies and to follow up with us as well. So it's always a collaborative effort.
I think what I've noticed, and I don't know if it'd be interesting to hear what everybody else has to say, but a lot of times we diagnose at endoscopy. We have open access endoscopy, and we see somebody and they come in with dysphagia, and then we're diagnosing them, and then we're trying to figure out how to follow. We're all very busy and booked out, and trying to figure out how to follow up. And having that collaboration with allergy is extremely beneficial, I think, in part for just making sure you have that continuity of care, but also, I've learned so much from allergy, because there's times where I'll send a patient and I'm like, well, I think he has asthma, and then they'll come back and say, well, yeah, he's got some mild asthma, but did you notice that he has nasal polyps? I'm like, no, I did not notice that. So I think that ultimately getting that global perspective is very helpful. I used to be able to work with an allergist in my clinic, but I think that's kind of a pie in the sky kind of thing, where you can work closely with somebody in clinic. But I think having somebody that you feel comfortable that you can have that conversation with has been really helpful for me to have a set of clinical allergists that I work with closely.
So in general, allergists are not always in academic centers. I mean, there's more allergists in private practice than in academic centers. So it shouldn't deter you from, if you don't have an academic center close by, there's plenty of allergists in the community. And we talk about EoE in the allergy meetings all the time. So working with your community allergists is really highly recommended.
Sorry. See, I talk too much.
Oh, go ahead.
But I think it speaks also really well to, because there's some reports when patients are doing diet and they're doing food reintroduction of having severe allergic reactions. And so being able to work with the allergist to try to to predict if there's going to be something once somebody takes a food out of your diet and bring it in, that's been really helpful for me to have that relationship.
Yeah, that's a very good point. Thank you. The reason being is, as you saw, this child was really allergic from day one. And now we've learned that actually introducing the foods takes away the allergy, like the LEAP study where we found that if we start patients on peanut early on, children who are at high risk of developing peanut allergy started on peanut early on and continuing into feeding of peanuts regularly prevents them from becoming allergic to peanuts. So when you take some of these highly allergenic foods out of their diet for extended periods of time, it allows the allergy to just pop its ugly head again. And when you introduce them, then they might have anaphylaxis. So again, evaluating those patients before the introduction of the foods by an allergist is, again, highly recommended.
Yeah. And I think, as GI docs, of course, we have no training in how to deal with other allergy conditions. And so, you look at the data and you see 60 to 80% of EoE patients have other allergic conditions. What I've learned from, allergy colleagues is that, when they're seeing a patient who has asthma, eczema, and food allergies, all three of them need to be treated to control them all effectively. And so if on the GI side, if we're only treating the EoE and these other atopic conditions are not being managed, it can be very difficult to get the EoE under control. So I think that's another important point. And then, going with the diet elimination, I guess maybe just a show of hands, how many of you have actually done diet elimination for your EoE patients? Oh, all right.
Awesome.
Well, that's more than I was going to guess. I mean, as I think we all know as GI docs, we don't have, at least on the adult side, we don't have a lot of nutritional education and training at all. And so I think working with an allergist and also dietitians or nutritionists who often are in the allergy setting is really important to help, give the food elimination the best chance you can to get it going.
Yeah, probably the last point is that as allergists, we have become very adapted to utilizing the monoclonal antibodies that work against the allergic etiology of these diseases. So once more, since EoE is considered an allergic disease, once we have indications for these antibodies, monoclonals, for EoE, then we also might be a great help in the management.
Yeah, that's a great point. Okay, well, great. Well, let's go to the next case.
All right, so this is one, I have a case, it's actually a real case, so if anybody wants to help me, that'd be awesome. So this is, and everything's a little bit all not quite the same, but a male, mid-30s, came to my office after being referred up from primary care. And he'd been seeing his primary care complaining of chest tightness and kind of this intermittent squeezing sensation. So the primary care said, I think you have heartburn, and put him on a PPI. And then ended up upping the PPI to where it was high dose. And by that time, he'd probably been on it. I mean, it was greater than 3 months, I think, probably 4 to 6 months, and was still experiencing this kind of tightness and squeezing that was intermittent and very bothersome at times. So the primary care just referred him into GI. And so we saw him in clinic. And in clinic, this speaks a little bit to what Evan talked about, like those subtle signs. We were able to elicit that he actually does have pill dysphagia. Felt like pills were kind of slow to go down, and he had to wash them down a lot. And didn't like to eat chicken. Felt like chicken was too dry, or crackers kind of bothered him. And his partner said that he's usually the last one to leave the dinner table, so that ultimately every time they go out to eat, they're always waiting on him to finish. When you talked a little bit more to them about the pill, saying, hey, would you pop a pill? Would you, take this 800 ibuprofen? And they're like, no. It ended up being like, that's been ongoing for probably about 10 years. The chest pain's new, but the dysphagia had been ongoing for about 10 years. He endorsed asthma, said he'd been diagnosed with asthma, had a little bit of eczema kind of on the extremities, and some sinus disease with sinus congestion that would give him sinus headaches, and that would occur with the seasons. So he's on high-dose PPI, and we send him for an endoscopy, and this is what we see. And so I would love to have Evan comment on what he sees there.
I was going to ask you. All right. Well, this is obviously very, very abnormal. So you can see if I'm right, Kathy. Right. So if we're going to use the the EREFS scale, okay, let's go ahead and do that. So first of all, it's very edematous here. So you're not seeing any vascular pattern. So you get a point for the edema. There are rings. These are pretty subtle rings, I would say. They're not super prominent. You can see them here. So probably a grade 1 ring. The exudates are quite severe. This is clearly more than 10% of the esophagus, so it's 2. You can see furrows here. They're relatively subtle, at least in these pictures, so I'd probably say grade 1 furrows here. And then the tricky thing with this is stricture. So I'd like just to see a show of hands. How many people think that there may be a stricture in these pictures? Okay, so some. So I think this is one of the hardest things in endoscopy, to do, especially with still pictures. But it's, to me, and I'll get Kathy's take on this, but to me it looks narrowed. Okay, so you have a narrowing of the caliber in the proximal, and this looks pretty narrow here if this is going down into the mid-esophagus. When you're doing the endoscopy, you can sometimes feel like this little bumpy sensation of the scope going over the ridge, or it can feel snug. But this would be something where I would suspect it's more narrow than we would guess it would be. And I don't know what your sense was when you were looking at it.
Yeah, I called a stricture on it. But you're right. I mean, it's really hard. I mean, we ask you to do the EREFs, or we're saying we should go by the EREF score, but it's a hard thing to do sometimes. And that's, I think, why I wanted to show the case, too, that this is a very difficult situation because, and it was fairly what I felt like was kind of narrow and gave me some like tactile feedback even when I had gotten into the stomach. So my guess is that pretty much the left picture is up high, and then this is his mid-esophagus on the right. I felt like he had quite a long stricture. Now, some people would do a barium esophagram to really assess that, but I tend not to if I'm going to try to treat them, because then I'm like, well, why would I put you through radiation if you don't need it, right? Hopefully I will make some effect by treating him. So then the question would be, what would we do next to treat? Because he's already failed. This is on high-dose acid suppression, and I'm happy to have either one of you answer, because I can tell you what I did.
Well, let me ask you a question before you get to treatment. So, is this EoE? Would you diagnose it? Is there anything else you have to do right now to diagnose it, or do you all feel comfortable that it's EoE? Yeah. Does anybody think it's not, or you would be interested to see something else? Yeah. I mean, I think if we assume the stomach and small bowel are normal and everything, right? There's nothing else that really looks like this, in the esophagus. So I think here, when you get the biopsies back, you can feel comfortable that this is a positive diagnosis without a PPI trial to diagnose it.
The only other thing I think what maybe you were getting at too is that, like, we could potentially, we don't know if there's other like hypereosinophilic but he didn't have any other, just so you know. He had no other symptoms. So I called it EoE, so hopefully that's right. So then my question is, what would you do next? So he's on high-dose PPI therapy, and he's failed. So I'm happy to have.
So what would you do, Amal?
I would do the topical steroids in this patient first. Unless you felt that his stricture was really tight, then you might go ahead with dilation, but that's not my area of expertise. You wouldn't want me doing that. But yes, I would definitely do high dose puffed and swallowed steroids. at least if you're going to use the fluticasone or the budesonide, what's equivalent to 800 micrograms, 2 puffs twice a day.
Would
Now-
anybody do diet? Nope. Nope. Okay. So this is his follow-up on 2 months of high dose on budesonide, 1 milligram BID. So he's coming back in, still has his dysphagia. He basically was like, "You did not help me at all." So this is my scope. What's the next thing that you would think of at this point? Or what would you want to think about, I guess?
Yeah, so I think, the question I think for this is, why didn't he respond? And there's basically, one is he's really not a steroid responsive kind of person, but the big thing is did he take the medicine or did he use it correctly? And that's, I think, it's a key point to ask about. And I have patients who I would prescribe, say, a fluticasone, and the pharmacist gives them a spacer because they think it's for asthma. And so they're puffing it into the spacer, nothing gets into their mouth to swallow. So, is that going on? Is this someone who just didn't take his medicine? There's a number of different things. I've had people, sometimes I have a whole slide where I have these random things, but people would tell me they puff the fluticasone on their hand and lick it. For some reason, they might be actually inhaling it and not swallowing it. So there's all these different things that people do with these homebrew medicines that may impact why they're not responding, as opposed to they're taking it and it actually just doesn't work for them.
I think that's really important too. And I will tell you, some of my patients, when they're like this, definitely I have oh yeah, I totally take it when I remember conversation. And I'm always like, well, when do you remember? So I think compliance is really important. So he actually, in his defense, was pretty compliant. He has not been feeling great. It's mostly the chest pain that was driving him, less so the dysphagia. And I think it's because he's adapted to his dysphagia, but has been compliant and has not felt better. So I think somebody mentioned diet out there. I'd like to see what you guys think.
Yeah, that would be the next step, because remember how we said if pharmacologic management doesn't work, then we try the dietary management. That would be the next step. And given that he's 35 years old, probably you would maybe try milk and wheat elimination.
And then would anybody dilate him with the dysphagia not bothering him too much, but just the chest pain? Some people would? Okay.
It depends on what you see. On endoscopy, if you scope a little bit nicely, you may not dilate it.
Yeah, no, I think you can, I'd like to hear what you guys say, but I think you can speak to what the prominent symptom is, right, at that point. But I know there is some data out there to suggest that there are higher risks for food impactions. And so there's no right or wrong in this. I've not dilated, and then the patients come in with a food impaction the night that I didn't dilate them. Just, trying to show you how human I am. And then I've dilated and haven't done a great job when they basically said I had a food impaction 3 days later after I dilated them. So, but I think you're right. I think, maybe that's where, unfortunately, you can't really have that shared decision-making conversation because they're sedated, but.
Yeah, I think this is a patient that often I would have dilated the first time, actually, when I see that narrowing. And there's a debate, do you do some anti-inflammatory treatment first and hope that they open up? But it is safe to dilate them up front, and they get some relief, even though it'll hurt for a few days. And so I would do that. I would say the other option is if they want to do diet, that's a great option. Sometimes you can also tweak the formulation of the topical steroid. So if you want to stick with fluticasone, instead of the puffer, you can use the disc device in some people. If you crack that open, there's a blister pack with fluticasone powder that you can just put on the patient's tongue and they can swallow it. There's probably better drug coverage with that. Or you could try to switch to the budesonide slurry, either compounded or, yeah.
Oh, you're a good one to answer.
Yeah, so that's a good question. So the question was, is there a difference between budesonide and fluticasone? So I actually, we were able to do a randomized trial comparing the two of them, and they were very similar results. They both had very good results within the groups, and there wasn't a big statistical difference between the budesonide and fluticasone. If you look at the histologic responses, the budesonide may be up a couple of points, but generally it's about a 70% histologic response with both, at least with the kind of the homemade formulations. They were both tolerated well, and the side effects are very similar and relatively minimal. Similar rates of candida and not much systemic absorption with either of them. So I think for those, it's really what you can get in the insurance to approve and what the patient is able to take. But here you might end up using a higher dose of budesonide if you wanted to stick with a topical steroid as well.
That was my question, is whether there'd be anybody that would do steroid and diet in him.
Yeah, that was my question. I'll probably continue with the steroid.
And then start him on diet.
And diet.
Yeah. I could totally support that one.
Yeah,
So,
this is hard. And
yeah.
then the last option is actually putting a patient like this into a clinical trial. So, this would be ultimately, if something is approved, the kind of patient who may need one of those biologics or novel mechanisms. And if you do have these kind of non-responsive patients, I think for all of us who are involved in clinical trials, these are good candidates for those kind of studies. Sorry, we had a question over there.
Have you ever used the nasal spray?
Oh, the Flonase?
Yeah,
I read in one of the abstracts somewhere that they had used nasal spray. It's cheaper and it doesn't taste that great, but still goes down easily.
Yeah. It would be interesting because our pediatric GIs use the nasal spray a lot. I would like to hear.
It's a smaller dose, though. I mean, it's 50 micrograms versus you're trying to do 880 micrograms, so it's a much
lot of
smaller
sprays.
dose.
The one thing I noticed, I had some patients that couldn't afford it, and you're right, it's so much cheaper, but they were so frustrated because you have to turn it upside down and then you can't really spray when you're, so that was part of the problem, but, so we were trying to figure out that, but yeah, it is cheaper, and I know our pediatric GIs use it a lot, so that's why I was curious.
But then Flonase is over the counter, so a lot of insurances would not pay for it, whereas, of course, Flovent or is not over the counter.
Yeah,
So the insurance would cover
Yeah,
it.
but just to your point about the lower dose, if you want to try to get about 2 milligrams of fluticasone, that's 40 puffs of the Flonase inhaler per day. So it runs out pretty quickly. I think we had a question over here.
The fluticasone, when you swallow it, can you mix it with water or food? Question one. Number two, as far as dietary restriction, how long does it take for it to respond before you think it's a failure?
So do you want to do the fluticasone first?
Both of those Evan should actually answer, but I can just quote Evan. So Evan did a great study on like a viscous kind of vehicle for topical steroid, and so viscous I think is better. I think you can mix it in. Usually we talk with our pharmacists, but you can mix it in honey and syrup. You can mix it in. We've actually had them buy some of those elemental diets and mix a thickened slurry of that, and then take that down to kind of just be more of a coating kind of mechanism. There is the Splenda formulation, but I don't know, I cringe at the thought of Splenda, so I don't do that one. But I'd love to hear what you.
Yeah, pretty much whatever as long as it's viscous, it's okay. But you want to have people not eat or drink for about a half hour to an hour afterwards so it stays in the esophagus. And I do not routinely ask the patients to swish out their mouth and spit because I feel like they're going to end up swallowing and then again just wipe the med right out of the esophagus. And then what do you say about for the diet therapy? How long do you usually do it before you assess? And how long is before you say it doesn't work?
So at least 2 to 3 months. Yeah, so it's not a short term.
Question, when you do the index endoscopy and the biopsy, do you also biopsy the stomach and duodenum, or you just only do the esophagus? Second question, with the diet elimination, do you eliminate wheat only, or you do wheat and milk in the first time when you eliminate the diet, or you fail one and then you eliminate second one?
What do you do for the stomach and duodenal biopsies?
That's a great question. I think it's actively debated. But I usually, if I have somebody who I have a high suspicion for having EoE, I will go before the endoscopy, ask them nausea, bloating, anything. If they have any hint of any other symptom, I biopsy, and I do 4 in the body, 4 in the antrum, and at least 4 to 6 in the small bowel, and I avoid the bulb. Yeah. So, and I'll let Evan take or Amal take the.
Well, I would say that in the pediatrics, I've hardly ever seen a biopsy of the esophagus without the stomach and duodenum, at least in the index one, because there is always a suspicion that you have an eosinophilic gastroenteritis. But then that's in pediatrics.
Yeah, I think there's a variation. I mean, the pediatric GIs always biopsy everything because there's such a high threshold to get a kid under anesthesia to do it. I think on the adult side, if it's just dysphagia and there's no lower symptoms and the stomach and small bowel look good, the yield is very low. But if they have these lower symptoms or you see abnormalities, then you do. And so that's what's in the guidelines right now. But it's an area that's evolving. And then, so for initial diet elimination, wheat only or dairy and wheat?
Well, you could do dairy only, but I haven't seen wheat only be done. So it's wheat and milk or milk.
Yeah. There's a couple new randomized trials, one in kids that looked at dairy only versus 4-food, dairy, wheat, egg, and soy, and one in adults looking at dairy only and the 6-food elimination as a randomized trial. And interestingly, the histologic responses were relatively similar with dairy alone versus a much more restrictive diet. So I think there's some reasonable data just to start with either dairy or dairy and wheat now. Yeah, another question over there.
Elimination diets are obviously possible, but can you speak more to allergens? You can't stop breathing. It's really hard to move.
Yeah. Why don't you start with that?
Yeah, we're gonna let Amal do that.
Yeah, move to a place where there's no air allergens. So I don't know what that is. Maybe the moon. I don't know. But the initial, way long ago, the initial studies were actually pointing towards AO allergens as contributing factors to the eosinophilic esophagitis. And then there's been several case reports of EoE waxing and waning with the seasonal allergies. On the other hand, so the question would be, if you do like allergy shots, allergen, all immunotherapy, not all, but subcutaneous immunotherapy, does that help? And we haven't seen that to be the case. I mean, commonly, particularly in pediatrics, they come in with the allergic rhinitis that may have already been treated with the allergen immunotherapy or allergy shots, and they still have the EoE. So I don't think that's key in the management. You can manage that with the allergist, again, just to relieve them of the rhinitis symptoms, but it doesn't help the EoE.
Yeah. For me, for us in North Carolina, the allergy seasons are horrendous. You get this thick coating of pollen everywhere. And so this is one area where I collaborate a lot with the allergist, because if you have someone, they're not responding to the diet elimination, I find about maybe 15% of my adults are probably driven by aeroallergens. And then there's a real collaboration there as to what to do. And so that's an area.
It's something also, I think, it's a great question because it's something you also have to take in consideration when you're doing a diet on your patient. So if you do this 6 to 12 week diet, and then when they come back in to get assessed and it's in the middle of this awful allergy season and they fail, what does that mean, right? Does it mean that it's all aeroallergens, or could it also be the diet and they would have responded in the winter? So I have a patient like that. He responded to a 6-food in December, then came back when he was reintroducing, but reintroduced just dramatically when he had all of these pollens in the spring. And so we put him back on the 6-food in the spring to summer, and he failed. so it's, it's something to take into consideration also, because it's a frustrating, I think, it's a hard thing for patients to go through to do that diet. So it is a conversation with them.
I seem to see a lot of patients, when they come with dysphagia, they don't obviously have any reasons for the dysphagia. Do you routinely take biopsies to rule out eosinophilic esophagitis, even though they don't have any history of asthma or seasonal allergies, things like that?
Yeah, absolutely. So I think anybody who has dysphagia now should get biopsies in the esophagus. There was actually a question about this, is about, what proportion of EoE patients have a normal endoscopy, and it varies a little bit by age. I think in kids it may be, more like 20%. Adults now, I would say it's less than 5%, because if you really are looking for the EoE findings, you can see subtle findings or patchy findings, especially now with the high-def scopes. But I think you have to think about it, and you also have to think about it if you're considering empiric dilation, and you're just going to throw down like a 20 millimeter bougie. You got to be sure that the caliber is good. And so but bottom line is take the biopsies if someone's having dysphagia, even if it looks normal. And I think that's everything. So thank you so much for the attention and for the interaction. It was great to talk with all of you. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SQH860. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi Genzyme.